Okay, well, I think we will begin. Welcome, everybody. Thank you so much for joining us this evening for the Fetal Therapy Current Status and Future Directions Symposium, hosted by the Dunlevie Maternal-Fetal Medicine Center for Discovery, Innovation, and Clinical Impact. We hope to have many of these symposiums on different topics under the Dunlevie Center. And I thought that just by way of introduction to review the history of the center, which is very new and nascent, and give you a sense for its areas of focus and its research domains. Next slide. This center was really made possible by an extremely generous gift made a few months ago by Elizabeth and Bruce Dunlevie, who saw the potential for creating a hub, an intellectual hub for research and discovery right here at Stanford, focusing on maternal-fetal medicine and obstetrics. No such center had really existed at Stanford dedicated to this discipline. And so this really was a unique opportunity to leverage all the talent and all the collaborations we have across the Stanford landscape and beyond. But have a center, a focus, a place where these energies, intellects, creativity could work together to advance this field locally, regionally, and globally. And our mission is to empower an arc of discovery and implementation in maternal-fetal science. Our vision is in the end to save the lives and improve the health of expectant mothers and babies for generations to come. Next slide. And we really decided to take a holistic approach to what we would do, that we would embrace a trajectory of discovery across basic science, prenatal diagnostics, and therapy, which this symposium has as its focus, clinical trials, and onto population health. And underneath that trajectory of learning and discovery and creativity would be a solid and robust foundational research core that would allow for this work to occur in a coherent and systematic manner. Next slide. And then kind of in a schematic way, we envisioned not one area of focus, not one siloed point of interest, but rather really a spectrum across this very rich discipline. Whether we are talking about placental biology and its relationship with some of the great obstetrical syndromes and how we can use that information and what we learn to improve population health, and the same with embryogenesis and stem cell and genomics and biomedical design and their relationship to prenatal diagnostics and fetal assessment and fetal therapy, as well as clinical trials in maternal, medical, and surgical disorders. Next slide. And in a kind of a more directive schematic, looking very much in a goal-oriented, outcome impactful way, from the basic sciences through clinical trials, and then taking those discoveries and implementing them in a way that improves the health of an entire population. Next slide. So that is the vision of the Dunlevie Center. It is one that I think has attracted the energies and excitements of many people. We've just learned so much as we have been putting this center together. We've learned so much about the unique and wonderful talents, which we always knew existed at Stanford, but we learned more, and you will be meeting some of these individuals who are speaking tonight who really are at the forefront of their fields and can inform and help us move this discipline to the next level. If you're interested in learning more about the center, we have a beautiful website that was recently launched that can go through what we're about, the people involved. We are still populating this website with our collaborators and others, but it will give you a nice sense of where we are and where we hope to be. And with that, I will stop talking and hand things off to Dr. Yair Blumenfeld, who will be moderating this session and who is our Director of Fetal Therapy.
Thanks, Yasser, and thank you everyone for joining. We're really excited to have such a wonderful turnout, and really for these amazing speakers who have agreed to join us this evening into somewhat of a packed agenda. You know, when we were planning this event, we didn't realize it would end up being, you know, this in this particular forum, but we'll try to adhere to be respectful of your time and hopefully be able to come out of here, you know, pretty energized about fetal therapy and the possibility of looking at fetal therapy in a way that honestly has not been looked at previously. And we really think that is sort of the power of the Dunlevies and really the power of this specific area of inquiry as it relates to the Stanford environment. So in the next couple of minutes, I'll just try to give you a brief overview about where we are in fetal therapy and why we all think we're actually very well positioned to sort of lead the next phase of fetal therapy, if you will. This is a very outdated picture of the fetal and pregnancy health program, not the fetal therapy program. The fetal therapy program is a very small part of this particular clinical program. This picture is obviously pre-COVID. That's why we're not wearing masks. And if we had to take this picture again today, it would probably be triple the size. But the point is that it's really multidisciplinary, and it's headed by Dr. Susan Hintz, who's the director of the Fetal and Pregnancy Health Program. And the fetal therapy arm of that program, which is also very much multidisciplinary, is a subset of that. You know, when we think about fetal therapy, we're thinking about medical therapy and surgical therapy. And up until now, it's really the right-hand side of the slide, the surgical therapy, that's really gotten sort of the attention and really sort of the crown jewel, if you will, of other fetal therapy centers when you look around the country and around the world. And sort of the medical therapies, which do exist today, are sort of, you know, second fiddle, if you will. And hopefully, what we really think and sort of looking at the next phase is really developing, especially here at Stanford, this sort of medical therapy portion, along with some other advances in the surgical field, but really sort of thinking about the next phase of fetal therapy, particularly as it relates to medical treatments or at least combining surgery and medicine together. And sort of the approach of fetal therapy until now has been, or at least originated, in this mantra of taking pediatric surgery, and I know there are many or some pediatric surgeons on the Zoom today, and not to detract from them, but really the initial approach was to take a sort of an approach where you take the pediatric surgery and you put it into the fetus. And so if we take congenital diaphragmatic hernia, there's postnatal repair, and the initial approach was, can we repair it primarily in utero? With various successes. And over time, if we use this CDH example, or congenital diaphragmatic hernia, they say, okay, maybe we don't need to correct the primary defect. Maybe we can go in a sort of a roundabout, in this case, an alternative solution where instead of correcting the diaphragm, we actually just obstruct, or in this case, actually cut off the trachea, because there's a natural flow of fluid from the lung into the amniotic cavity, and we can expand the lung in that way. And with time, taking it even more minimally invasive, it was discovered that you can actually insert a balloon into the airway of a fetus. This is a fetoscopic image on the right-hand side, where you can actually intubate, if you will, the fetus while the fetus is still inside the uterus, and then deploy a balloon. So this sort of approach of open repair or replicating pediatric surgery in the fetus and then minimally invasive approaches is sort of where we've gotten to where we are today. And so if we think about what disorders interest us, and I'll just try to give you a very brief overview of the state of the union, especially here at Stanford, just to sort of get you thinking about what kind of advances we can start to think about when we put our collective minds together. So one of the staples in our program is complex twins, specifically monochorionic twins that share placenta, because these types of twins have these shared vessels, which cause a lot of problems, including fetal growth restriction and a condition called twin-twin transfusion syndrome. And so the current therapy for this is what's called operative fetoscopy, where we insert a fetoscope that's about 2 to 3 millimeters wide into the uterine cavity at approximately 18, 20, 22 weeks, and we can ablate these vessels with laser fibers. We're very interested in fetal lung masses, which can be quite large, and we use a variety of imaging techniques, including over here you can see 3D ultrasound, but we employ MRI quite frequently, and these can become quite problematic, shifting the heart to the other side and really leading to significant neonatal morbidity and sometimes mortality. And luckily we have David Kornfield, who will talk to us about lung biology in a few minutes. And so sort of the approaches that we employ for significant lung lesions include both drainage and putting these shunts into the chest of the baby, and thereby diverting fluid into the amniotic cavity and relieving the compression. We have a robust multidisciplinary program looking at fetal lung and other genitourinary anomalies, including something called LUTO, which you can see is not a very subtle defect. These are ultrasound images in the first trimester. We have a very robust first trimester imaging program here at Packard and affiliated ultrasound sites, where you can easily identify an obstructed bladder. And over time, you can consider deploying shunts, again, these sort of pigtail catheters, which go in between the bladder and the amniotic cavity to divert urine and relieve the pressure there. We collaborate extensively with our radiologists, neonatologists, and pediatric surgical specialists, including ENT, to address fetal anomalies related to the airway. And here you can see severe examples of fetal lung masses, or what we call retrognathia or micrognathia, very retracted mandibles that will undoubtedly lead to severe and significant neonatal respiratory distress. And in these cases, we collaborate with pediatric surgery and other surgical subspecialists, along with neonatology, to perform something called an exit procedure, where you can see at the time of delivery, half the fetus is still inside the mom receiving oxygen, so that our pediatric surgical colleagues can actually develop an airway while the baby is getting oxygen via the placenta. And I should mention that this could not be possible without outstanding OB anesthesiologists, which help us manage moms in what can be quite a complex procedure. We collaborate extensively nowadays with our pediatric neurosurgeons, and again, vis-a-vis neonatology. So we are able to identify fetal spina bifida quite early on in gestation. We utilize advanced imaging techniques, including fetal MRI. We have outstanding OB radiologists, MFM and pediatric radiologists that are able to delineate the exact location of the lesion. And in classic repair terms, these are typically repaired in the first day after the child is born. And this is Dr. Grant and his colleagues repairing one of the lesions here at Packard. But what we know today is that in a select group of cases, you can actually perform in-utero repair. So you can actually perform a similar repair to the postnatal repair. And the benefit of this is to improve the likelihood that the child will be able to walk and improve the CNS morbidity that's associated with these lesions. And this is what it sort of looks like. So you can see we performed the surgery at around 25 weeks gestation. The uterus is exteriorized. We're able to identify the spinal lesion here, and our neurosurgery colleagues are able to repair this lesion. And then we close the uterus. And obviously there's a lot of work that's involved with many, many teams. And these patients are able to reach near term and deliver. And these babies are actually don't need further repair beyond this. So looking towards the future, one of the areas that we're really interested in is sort of converting a lot of these open techniques to more minimally invasive surgical techniques. Here you can see fetoscopic myelomeningocele repair, so similar to open fetal surgery, but through smaller trocars rather than a hysterotomy that is needed for open fetal repair. We've spent quite a bit of time on novel patient experience tools. In this case, we've developed a fetal therapy VR tool aimed at two conditions at this point. One is the twin-twin transfusion syndrome, and the other is fetal spina bifida. And you can find this on YouTube and on a link to the LPCH website. We're starting to look at novel surgical instruments. In this case, we have partnered with the Biodesign program and our pediatric urology colleagues to develop a novel shunt that hopefully will address certain deficiencies of the existing shunts, including dislodgement risk that can lead to significant prematurity risk. And then finally, we've spent a lot of time over the last couple of years developing robust data sets of our local outcomes, both in terms of identifying ways of improvement and also to start thinking about better ways of predicting outcomes and new analytic approaches to clinical outcomes research. And we have a variety of data sets that are under IRB and REDCap storage. We're part of the North American Fetal Therapy Network. We're actually one of the leading sites. There are about 43 centers, and we participate in both retrospective registries that are a part of the network, as well as prospective trials, including NICHD supported trials, such as the GOOD study looking at fetal gastroschisis outcomes, and a pretty prominent study called the Renal Anhydramnios Fetal Therapy Trial, or the RAF trial, where we're a part of 7 or 8 centers, assessing whether serial amnioinfusion improves lung development in utero in cases of bilateral renal agenesis and other severe renal anomalies. Which brings us to today. So this was, the concept of today originated from a basic science sort of group within our department, and they suggested that we hold a Stanford Symposium where we get people who are not necessarily used to thinking about fetal medicine or fetal therapy to see if we can develop new collaborations and new ways of thinking. And we had several meetings and we sort of led to what we have today. And so when we started thinking about this, we knew that this is LPCH, and hopefully all of you guys know that this is LPCH. If not, this is the beautiful glass building that's across of where where some of us are sitting today. But we have all of this as well, and that's where all of you come in, where clearly our interest is to expand beyond our borders and to get people from different disciplines. And we have people from the Department of Chemistry today and others, Professor Wendner, and we're really excited about the potential of leveraging this amazing university, this amazing infrastructure, and people from all disciplines or multiple disciplines to really advance the science. So our goals is, in an ideal world, we would meet each other in person and have, something to drink afterwards, but we realize we're still in COVID, and hopefully future meetings, we can meet each other in person. But at the very least, we can use this as a nidus to develop novel collaborations. Hopefully we can start to think outside the box. Hopefully all of us can have our sort of thinking caps on as we're listening to these talks and think about new ways of collaborating and really advancing the science. And then again, we really, really hope to leverage inherent strength, both individually and as an institution. These are tonight's speakers. Each one will have approximately 15 minutes. We've divided the symposium into 3 topics: organ development, stem cell and gene editing therapies, and then medical therapies. And what I'd like to do is each speaker will present for approximately 15 minutes. And then at the end of the talks for the individual topics, we'll then have a few minutes for Q&A, and all of you guys will be able to ask questions on Zoom. And then we'll have breaks. So we'll do organ development, then a Q&A, and then break, and then stem cell and gene editing, et cetera, et cetera. And hopefully we'll be able to finish this by 8:30 and not much later, to be respectful of everyone's time. And so let's get started.